necrosis. So by different pathways and different method, they've found to have a lot of cardiovascular benefit for this molecule. So today, in my outline of the talk, we'll see what the guideline has to say about this molecule in this subset post-MI patients. What are the randomized and non-randomized studies? What are the ongoing studies? And the safety of this molecule, and to summarize my talk. So this was the 2023 ESC guidelines for acute coronary syndrome. And when you see the guidelines, they've just given a small mention about the EMI trial, which was where empagliflozin was tried in post-MI patients. They found to have significant improvement in the NT-proBNP, as well as echocardiographic functional and structural parameters over 26 weeks in post-MI patients. But the last statement was, the ongoing outcome trials in ACS population will be useful to better define the role of these agents in the absence of heart failure. So the data is lacking to give a guideline for using this molecule in post-MI patients. So no recommendation for SGLT2 inhibitors in post-MI patients. There are a few randomized control trials, non-randomized control trials favoring the use of SGLT2 inhibitors in post-MI patients. So we need more data for the from the ongoing trials for any guideline recommendations. You will see what are the studies in this subset. The first, the EMI trial, which I've just mentioned, which was mentioned in the ESC guidelines. This is in post-MI patients. It's a multicentric, double-blind randomized control trial, total of 476 patients, a small randomized control trial. Were 237 in the EMPA and 239 in the placebo arm. The primary outcome they looked upon was the NT-proBNP reduction, as well as the secondary outcome was the echocardiographic parameters like the LV ejection fraction, diastolic function, end systolic volume, and the end diastolic volumes. So the study population was patients with myocardial infarction with significant myocardial necrosis. They excluded patients with eGFR of less than or equal to 45, excluded patients who are hemodynamically unstable. Now coming to the results, they've shown there is a significant reduction in the NT-proBNP in 26 weeks post-MI. There was around 15% lower NT-proBNP in the EMPA arm when compared to the placebo, and the p-value was significant. You can see the echocardiographic findings. The LV ejection fraction, it actually improved by 11% in the EMPA arm. There was improvement in the diastolic function. Also, there was significant reduction in the LV end systolic and the LV end diastolic volume. So, the echocardiographic findings and the biomarkers, the NT-proBNP was favoring for empagliflozin in the post-MI patients. So there was a significant reduction in NT-proBNP in 26 weeks, improvement in the LV ejection fraction, diastolic function. There was a reduction in the LV end systolic and end diastolic volume, but no hard clinical endpoints was studied. This was the limitation. The sample size was insufficient for any hard clinical outcomes. Now this another small randomized control trial, it's embodied trial where they've looked upon the effect of empagliflozin in the cardiac sympathetic activity in a post-MI patient. So 96 patients were enrolled, 46 in the EMPA and 50 in the placebo, and they've looked upon the heart rate variability to know the sympathetic activity and the heart rate turbulence, and they found there was significant improvement in the heart rate variability and turbulence in the EMPA arm. Again, a very, very small study. You can't make much of a recommendation with this small sample size. Now, there was an SGLT2 inhibitor AMI Protect registry. This was a registry where 46 patients with diabetes were enrolled post-MI who undergone PCI. 111 the SGLT2 inhibitors, 535 in the patients without SGLT2 inhibitor. The mean follow-up was 24 months. They found the same improvement in the cardiovascular mortality, heart failure, hospitalization, MACE, also improvement in the in-hospital mortality and reduces the arrhythmia. Again, it's when take it as a registry, it's a small study for just 646 patients and observations. So these are some of the limitations of these studies and registries. Now, this another one, which was a Korean-based, population-based study. It is a were 2,814 diabetic patients presented with acute MI who underwent PCI was enrolled. 938 in the SGLT2 inhibitor arm and the 1,876 without SGLT2 inhibitor. 2-year clinical outcome was looked upon. So this was the outcome. You can see there was significant improvement in the primary outcome, which was all-cause mortality and the hospitalization due to heart failure. The secondary outcome, which was the composite of all-cause mortality, hospitalization due to heart failure, and non-fatal MI and non-fatal stroke, was also significantly improved. When you see individually, the mortality, all-cause mortality was also significantly improved, and the hospitalization due to heart failure was also significantly improved. But there was no significant improvement in the myocardial infarction or ischemic stroke. So this was the concluding statement that the early use of SGLT2 inhibitor in the diabetic treated with PCI with acute myocardial infarction was associated with a significant lowering of the cardiovascular events, including all-cause mortality, hospitalization due to heart failure, and the MACE. Again, it's a retrospective observational study. Now this is the DAPA-MI trial, which was recently published in the recent ACC-AHA conference in November 2023. This is an international registry-based randomized controlled trial. The objective was to evaluate 1-year outcome of the composite of death, heart failure, hospitalization, cardiometabolic factors in patients with acute MI randomized to dapagliflozin. There was 4,000 patients enrolled with DAPA 10 milligram and versus placebo. The inclusion criteria was MI within 10 days. Patients with impaired left ventricular ejection fraction, left ventricular systolic function, or a Q-wave MI, hemodynamically stable patients were enrolled. The exclusion criteria was patients with diabetes, patients already having a chronic symptomatic heart failure or a reduced ejection fraction, and eGFR of less than 20 was also excluded. Now, some of the important baseline characteristics, the mean eGFR was 83. The baseline LV ejection fraction less than 30% was 6.5%. Between 30 and 49, it was 67%. So around 20% of the patients were having the ejection fraction of more than 50. So even a fair LV function patients were also enrolled in this trial. And we see most of the patients were on guideline-based therapy. The amount of AC inhibitors or ARB was around 92%. The beta blockers were 89%. 72% of the patients were STEMI. The HbA1c was 5.7%. The primary endpoint was the hierarchical composite of death, hospitalization for heart failure, non-fatal MI, atrial fibrillation or flutter, diabetes, NYHA class, and weight decrease of more than 5%. The primary endpoint for dapagliflozin, the win ratio was 1.34. That is, there was 34% better improvement with the dapagliflozin when compared to the placebo, and the p-value was significantly improved. The secondary endpoint was hierarchical composite of death, hospitalization, heart failure, non-fatal MI, atrial fibrillation, flutter, type 2 diabetes, and NYHA class. The win ratio was 1.2%. But when you individually take the MACE, the major adverse cardiovascular events like MI, stroke, or death, there was no difference. When you take the cardiovascular death or hospitalization, there was no difference, and all-cause mortality was also not different. So the major contributors for the improvement was mainly the diabetes, the reduction in the weight loss, and so the hard endpoints was not found to have any clinical significance. So there was significant improvement in the cardiometabolic outcomes without any effect in the cardiovascular mortality or hospitalization to heart failure. No major safety concern. Now this is the ongoing trial with the IMPACT-MI trial, where empagliflozin was tried in this subset of post-MI patients. This patients with spontaneous MI with no history or no past history of heart failure or LV dysfunction. The patient should have the signs or symptoms of heart failure requiring treatment, or a newly reduced ejection fraction of less than 45%, along with at least one additional heart failure risk factor such as age, CKD, or biomarker levels. So this, the IMPACT-MI is different from the DAPA-MI because here more high-risk patients are enrolled when compared with DAPA-MI, low-risk patients were enrolled for the trial. We are waiting for the data from the IMPACT-MI. It's an ongoing trial. The safety of SGLT2 inhibitors in post-MI patients, when you see the major adverse events, most of them are, the common adverse events are not very concerning, like there can be genetic mycotic infection, urinary tract infection, there can be hypoglycemia when combined along with the sulfonylureas or the insulin, and there can be volume depletion. The rare complications, adverse events are not very frequently seen in our clinical practice. To summarize, in the EMI trial, they found there is improvement in the NT-proBNP and the echocardiographic parameters. The SGLT2 inhibitor AMI PROTECT registry, they found there is improvement in the cardiovascular mortality, heart failure hospitalization, and MACE. The Korean observational study, they found there is a lower incidence of mortality, heart failure hospitalization, and MACE. In DAPA-MI, they found there is improvement in the cardiovascular outcome, but not in the cardiovascular mortality or the heart failure with hospitalization. So the take-home message is, small randomized control trials, subgroup analysis, observational studies, and registry have positive data for SGLT2 inhibitor in different subset of post-MI patients, but need more robust data to give SGLT2 inhibitor in all post-MI patients. Thank you. So we still, the data is lacking. Maybe the ongoing trials give us more wisdom in this, using this molecule in this subset of post-MI patients. Thank you.
Thank you, Dr. Kiran, for the nice talk. What is your opinion, what is your practice regarding this SGLT2 inhibitors in post-MI patients? Do you use them regularly or?
Not regularly, sir. In selected patients, if the patient is hemodynamically stable and having some LV dysfunction, I think after stabilizing the initial event of acute MI, I think we can start the SGLT2 inhibitors. But not in all patients, not in patients who is hemodynamically unstable, not in the acute event, during the acute event. Maybe we can wait for a few days to stabilize the patient and start if there is LV dysfunction. If there is no LV dysfunction, still we should think twice before starting this molecule.
Kiran, have you seen any effect on hypertension or blood pressure with SGLT2 inhibitors?
Sir, usually not, sir. Not much difference. Maybe the diuresis might result in some BP reduction, but not very significantly.
Anyway, one good thing about thing is there is actually no safety issues regarding starting SGLT2 inhibitors in this setting. That is one good thing.
Yes, so the DAPA-MI trial, it's actually the hard clinical endpoints has not been met. But one thing which made that trial is that it's shown that there is no safety issues with the starting this molecule in the acute MI subset. The rest, whatever the data which they have shown is only because of the improvement in the diabetes, improvement in the weight loss. Rest, the hard clinical endpoints has not been met. So safety issues is not there, but so you can give in selected patients.